Today I'm going to talk about a very important topic and a common presentation in emergency department. That's GI bleed. Before going into the details of GI bleed, I would like you to know how to approach a patient with any presenting complaint or especially GI bleed while you're working in emergency department. The mnemonic of ABC, airway, breathing, and circulation, is so much important for a working emergency physician that applies to any disease or any complaint the patient comes with in the ER department. Let's focus on GI bleed. So, in this diagram, you can see ligament of Treitz. Bleeding above ligament of Treitz is called upper GI bleed, and below it is called lower GI bleed. So one has to recognize if this patient is having upper GI bleed that can present with hematemesis and melena. Hematemesis and melena is black colored stool, foul colored stool, while hematemesis is coffee ground vomitus or blood in the vomitus. While patient can present to you with lower GI bleed that bleeds below ligament of Treitz, that can be red, bright red colored stool. Before going into the details of how to manage a patient and what to do, let's review what to do when you receive a patient with GI bleed. I'll spend some time on this slide because it's very important. History of evidence of GI bleed, or patient comes to you for the first time with GI bleed. Before going further or going into the diagnostics, that if it's a lower GI bleed or upper GI bleed, first you need to do something that can help patient save life. That's hemodynamic stability. How to do that? Let's move further. Active profuse hematemesis or haematochezia. Haematochezia is fresh pre-ER bleed or dark colored perectal bleed. Yes, that's major acute gastrointestinal tract bleeding. What are the risk factors? Severe liver disease. Patient have a history of hepatitis C. DCLD, decompensated liver disease. Advanced age. Coagulopathy. Patient is using blood thinners. Cardiopulmonary diseases can be a risk factor for GI bleed. If there is no active profuse hematemesis or haematochezia, obtain vital signs and examine for shock. What type of shock would occur in a patient with GI bleed? Yes, hemorrhagic shock, and that's due to blood loss. So, and if there are signs of shock, hemorrhagic shock, what are the signs of hemorrhagic shock? Hypertension, altered mental status, decreased saturations, increased pulse pressure, decreased pulse pressure, increased pulse rate. These are the vital signs. Cold, clammy skin, these are the vital signs recognizing that this patient is in hemorrhagic shock. What to do in this patient? First, in this diagram, insert 2 large bore IV cannulas. What to do? This patient needs fluid and blood transfusion. Next step, take a blood cross match. PT and APTT. Complete blood count, serum electrolytes, liver function test, creatinine and blood urea nitrogen, the renal function test, glucose levels. What to do next? Infusion of 2 liters of crystalloid IV fluid. You have to maintain the mean arterial pressure of 65, more than 65. But the patient is losing blood. Will crystalloid replace blood? No. What to do? Blood cross match, urgent request for blood arrangements and blood to be transfused as soon as possible. Next, airway. What to do in airway? Give oxygen 5 to 10 liters via nasal cannula or face mask. If a patient is with low GCS, that's less than 7, this patient needs intubation. You have to protect the airway. Next, abdominal examination, rectal examination, stool for occult blood examination. These are very, very important. This can give you a rough idea where is the patient bleeding from. Urinary catheter insertion. Why? Because in shock, the patient should be having enough urinary output. You have to see the urinary output. That's 0.5 to 1 ml per hour per kg per hour. A nasogastric tube, NG tube in short. What to do? Aspiration, gastric lavage. Why? You have to realize if this patient is having an upper GI bleed, and this lavage can help the endoscopic surgeon to visualize the bleeding point accurately. If the patient is unstable, what are the signs of instability? Cold, clammy skin, altered mental status, hypotensive, transfuse uncross-matched blood. That's O negative blood. Despite waiting for the matched blood, you might lose the patient, but you can give O negative uncross-matched blood. Coagulopathy, give vitamin K and fresh plasma. And the patient should be admitted in ICU, intensive care unit. So again, I'll summarize this for you. When you receive a patient in GI bleed, while working in emergency department, first and the foremost thing you have to realize, airway. Is airway secure? No, you have to intervene. Oxygen mask, non-rebreathable mask, or might be the patient needs intubation. Next is breathing. Is the breathing symmetrical? Is the patient breathing adequately? Next is circulation. That's more important in GI bleed. Are the organs being perfused adequately or not? That's the main point to be considered in patient when you receive with GI bleed. Then, IV cannulas, large bore IV cannulas, rapid transfusion. This patient needs rapid transfusion. Rapid crystalloids, 2 liters of crystalloid infusion. This can help save patient's life. So, what are the signs of shock? That hypotension, blood pressure of less than 80, postural hypotension, or the features of shock. But if the patient is stable, with GI bleed is stable, and there are no signs of shock, then one must proceed further for history and the other relevant examination. Let's move on. If there are no signs of shock, obtain a history from brief examination, venous excess, hematocrit levels, PT and APTT, and blood type, and for cross-match. So, nasogastric lavage, as I mentioned before, if there is documented hematemesis or blood in nasogastric aspirate, nasogastric aspirate without bile or blood, but with melenic stool, or hyperactive bowel signs. What are these features for? Upper GI bleed. But in nasogastric lavage, no documented hematemesis. Nasogastric aspirate without blood, there is maroon or fresh red rectal bleeding. Haematochezia with normal hyperactive bowel sounds, think of lower GI bleed. So, in this slide, you would appreciate how to approach a patient with GI bleed. What to be considered first, and what are the signs of shock, and what to do in this patient who is in hemorrhagic shock. So the gold standard, the take-home point in this slide is instability, large bore IV cannulas, rapid blood transfusion, and look for a bleeding point. So, how to determine a site of bleeding? As I mentioned in the first slide, under the section of anatomical essentials, that the bleeding above ligament of Treitz is upper GI bleed, and below it is lower GI bleed. What are the characteristics of upper GI bleed? That's hematemesis, coffee ground vomitus. That's blood in the vomitus. You have to ask the patient, that will be I'll explain more in the what questions should be asked for the patient with GI bleed in the next section. But you have to ask a patient with hematemesis, what color of blood did he or she notice? If it's clotted blood, if it's fresh blood, or this is black blood. That's a very, very important diagnostic point. But with clotted blood, one can realize this is a heavy bleeding. Melena, that's dark, foul-smelling stools, black color stools. Haematochezia, that's reddish or maroon stools or fresh blood from parectal area. Lower GI bleed, hematochezia. Characteristics of lower GI bleed is hematochezia, that's fresh bleed. Melena at times can present with lower GI bleed, but melena is more common in patients with upper GI bleed. Bright red blood stool, absence of bleeding. These are all the characteristics of upper GI and lower GI bleed. So moving on to how to approach in a patient with hematemesis and upper GI bleed. That's suspected upper GI bleed. How would a patient present to you? He might present to you with history of hematemesis, that there is a blood in my vomitus. He might present to you that with black colored stool. How to approach? So, clinical trials. How to do it? Look for stability, unstable or with evidence of shock, or the patient is stable. If the patient is unstable, you need to resuscitate. How do you do that? As I mentioned before in my previous slide, what are the signs of instability? Hypotension, the systolic blood pressure of less than 80, altered mental status, cold clammy skin, tachycardia, altered mental status with decreased GCS, and how to resuscitate: airway, breathing, and circulation. Large bore cannulas, crystalloid infusion, and blood infusion. These are the very important things to do in a patient who is unstable and present to you with GI bleed. If the patient is stable, go for nasogastric lavage. What to look for? If it's negative for melenic stool or rectal, or if it's negative, there is no blood in aspiration in nasogastric tube, look for melenic stool on rectal examination. How do a melenic stool look like? It's a dark colored stool. If there is no, consider other cause of shock. But if there is melena in rectal examination, that's pyloric upper GI bleed. If nasogastric lavage tube is aspiration reveals blood, that's upper GI bleed. What to do? Consult GIT gastroenterologist or general surgeon. What this patient needs, it's endoscopy. How do you do that? That's the domain of the gastroenterologist or general surgeon. They need to find out the bleeding point and to embolize it and to stop it. But this all can happen if the patient is stable. Once again, you have to check for stability of this patient. So if there is active bleed on aspiration or aspiration and blood in aspiration on nasogastric tube, consult gastroenterologist, general surgeon, and this patient needs ICU admission and might go into explorative laparotomy if there is no signs of bleeding on endoscopy. If the patient is stable, again, go for nasogastric tube lavage. Red blood there is continued red blood, again, consult GIT, a gastroenterologist, and general surgeon. If there is blood clears or coffee ground substance present, or there is there is no blood in gastric lavage, consider other source of bleeding or post-pyloric upper GIT bleed. But if there is coffee ground substance present in aspiration, clinical status, look for stability and stability. If the patient is with normal hematocrit, normal coagulation profile, and vitals are normal, there are no signs of shock. If there are these normal values are not present, this patient might need admission or gastroenterologist consult. Next, if the patient is with normal hematocrit, normal vital signs, no signs of sepsis or no signs of shock, this patient could be sent home and asked to follow up in OPD. That's outpatient department. So that's how you approach a patient with GI bleed. So now this comes when the patient is stable. What questions you need to ask in a patient with GI bleed? History is very, very important. Where are you bleeding? How much a patient know about the disease? If it's bleeding from rectum, or is there any bleeding from upper GI tract? You need to ask the patient, what brings you here? What type of GI bleed is there? Are you having coffee ground vomitus, or you're having a melena or black colored stool, or do you have maroon or bright red colored stools? You need to ask. Does your vomitus look brown or look like coffee ground? Signs of upper GI bleed. Have you had dark tarry or sticky stool? That's melena. Foul smelling stool? That's also a feature of upper GI bleed. How much bleeding have you had? This is a very difficult question. At times, with especially patients presenting with lower GI bleed, they tend to notice if that's a painless disease, painless bleeding, they tend to notice when using a toilet paper. But you can ask for how long the patient you're bleeding, how many episodes, if it's with clotted blood, if it's with fresh blood. Clotted blood is a sign or significant sign of heavier blood loss. And it's a sign the patient is bleeding for some significant amount of time. So how much have you bled? That's an important question. When did the bleeding start? Was it spontaneous? Was there any gradual increase in it? For how long is the bleeding going on? The time duration is very, very important. At times, patient might not present to you with active bleed when they reach an emergency department, but previously they're having a significant amount of blood or blood loss. So how do you assess it? For how long is this patient bleeding? For example, if a patient comes to you and says, I've been bleeding for the past 3 days, this patient is prone to get instability. What to look for and the timing of the bleeding. If it's spontaneous, if there's any rupture, that signifies the time of bleeding. Is the bleeding painful or painless? Painful is most commonly with inflammatory diseases, for example, inflammatory bowel disease. Painless can present to you with diverticulosis or carcinomas. Do you have any vomiting or retching prior to hematemesis? A significant point in Miller-Weiss syndrome. There is a heavy amount of vomitus, or this retching or stretching can produce hematemesis. These are more prone in patients who are alcoholic and with esophageal varices. What other symptoms do you have? A very, very important point. What are the symptoms you have to look for? Is there any dizziness, signs of hypotension, any blackouts, or signs of altered mental status, signs of fever, any pain, abdominal pain? Have you had any gastrointestinal bleeding before? 60% of the patients have a history of GI bleed. They have risk factors will be explained later. But this is a very significant point. What other medical problems do you have? A history of other medical problems, and that can lead to GI bleed is very, very important. For example, if the patient is with hepatitis C, decompensated liver diseases, they can present to you with hematemesis or melena, alcoholic liver disease. Patients who are known case of carcinomas, they can present to you with GI bleeds. Patient with history of hemorrhoids can present to you with lower GI bleed. What medications do you take? Coagulopathy, patients who have blood thinners, warfarin, they can present to you with bleed. What prior surgeries have you had? Any abdominal surgery, scar marks in abdomen, can present to you with aortic fistulas. This can demonstrate a bleed. So these are very important history points that need to be asked in a patient who is stable but with GI bleed. Any endoscopic procedure before? Was there any signs of erosions or ulcers or bleeding before? And if there were, what was done with that problem? And this might be a recurrent of that problem. So these are very, very important history points that can help you to make a diagnosis or at least reflect that this patient might be having upper GI or lower GI bleed and what to do in patients with GI bleed. So moving on to physical examination. When you receive a patient in emergency department, what signs you have to look for in a patient with GI bleed? First, signs of instability. Is airway compromised? How is the breathing? How is circulation? But my emphasis would be concerned about GI bleed. Hemorrhagic shock. How would a patient with hemorrhagic shock would present to an ED? What would be the general appearance? What would you see in that patient that can make you understand or realize this patient is in shock? Cold, clammy skin. This patient, when you touch the patient, he's cold. The patient is cold. So what does that mean? This patient is in shock. Volume depletion. Cold, clammy skin. Peripheral skin is cold. Pale skin. Signs of blood loss. Anemia. Altered mental status. Low GCS. So mind if I tell you with low GCS of less than 7 or less than 8, what you have to do? Intubate the patient. Protect the airway. Respiratory distress. Signs of MI. Patient can present to you with chest pain and ongoing GI bleed. So these are the signs or general appearance that can help you signify if the patient is stable or unstable, and what to do if the patient is unstable. What you should know is how to treat a patient who is unstable with GI bleed. That's been mentioned before in the previous slide and at the beginning of this lecture. So physical examination, what are the vital signs? Blood pressure, pulse pressure. What it signifies? Hypotension, decreased fluid or blood loss, excessive blood loss. Hypertension, what does it cause? Decreased perfusion to the organs. So you have to look for blood pressure, heart rate, tachycardia, that's reflex tachycardia due to anemia due to blood loss. You have to look for temperature. You have to look for saturation, airway. If this patient is getting oxygenated adequately or not. You have to look for signs of external bleed. These are very, very important points, vital signs that you have to look for in physical examination. Head to toe examination. Head, ear, eyes, nose, and throat examination. You could find a bleeding point in throat. So you have to examine from head to toe if in patient with GI bleed. Abdomen. Look for any gross ascites indicative of any portal hypertension that can be due to a liver cirrhosis or liver carcinomas, or hepatocellular carcinoma due to hepatitis C, or decompensated liver diseases. Budd-Chiari syndrome. These can present, they can have features on abdomen. On examination, you can find a scar mark. So these are very important physical examination points that can help you make a diagnosis, or at least find a cause of why is this patient bleeding, what is causing this patient to bleed. Rectal examination, very, very important. What to do? Rectal examination, what reveals? Any fresh blood or any melena. At times it happens when you receive a patient in an emergency department, this patient might not be having an active bleed or no signs of active bleed. But you have to look for. Rectal examination can help you differentiate or tell you or give you a baseline information if this patient is bleeding or not. What to look for in rectal examination? Fresh blood or melena. Melena is a sign of upper GI bleed. Fresh blood can be a sign of lower GI bleed. Skin. Cold, clammy skin. Pale skin. These are signs of anemia and blood loss. So it is very important to palpate abdomen or extensive examination of abdomen. Why is this so? Because tenderness all around the abdomen can help you make a diagnosis. For example, patient with peptic ulcer diseases. There might be signs of chronic liver disease. Elderly patient with out of the proportion pain, mesenteric ischemia. Apart from abdominal examination, patient with GI bleed should be monitored after every 15 minutes. How? By checking the vital signs. Vital signs should be reassessed every 15 minutes. Why is this important? Because these help you to make sure the patient is stable. What are the vital signs to be considered? Again, blood pressure, heart rate, pulse oximetry, and temperature. If the patient is hypotensive, what to do? You know, crystalloids and blood transfusion. If the patient is tachycardic, that's reflex tachycardia due to hypotension. Temperature, cold, clammy skin, help you make sure the patient is going into shock or having features of shock. Decreased saturation. If the patient is not getting oxygen enough, the organs are not being perfused. So what to do? Oxygen supply. So moving ahead, diagnostic testing. It's a very, very important and can give you information within short period of time. Look for occult blood. Complete blood count. What does it show? Increased white count, inflammatory process. Decrease hemoglobin levels. Less than 8 needs transfusion. Indication for active bleed. Hematocrit levels. Decreased hematocrit, low blood count. Blood urea nitrogen and creatinine levels. Why is this important? There are two things to be considered while taking consideration of renal function test. Patient with increased creatinine and blood urea nitrogen think of organ hypoperfusion. And the patient with shock should be having an internal catheter to be monitored about the urinary output. So patients who are compromised, organ compromised due to hemorrhagic shock, they won't be able to make enough urine, or urinary output could be less. Type and cross-match. Again, blood should be replaced with blood. Crystalloid infusion can help you for some time to maintain the intravascular volume, but blood should be replaced with blood. Urgent cross-match and blood typing should be done. If urgent of cross-match is not available or blood is not arranged, one has to go for an O negative or uncross-matched blood, because this might save the patient's life. Active bleed should be considered emergent and should be given blood as soon as possible. Prothrombin time, very, very important. Patients who are taking warfarin or are anticoagulants, blood thinners, increase INR ratio. That's indication for fresh frozen plasma. This patient needs fresh frozen plasma. ECG, patient can present to you with chest pain and ongoing GI bleed. Look for any signs of MI. Look for MI. ECG won't take much of your time, but can help you make the diagnosis within no time. Nasogastric tube, nasogastric aspiration. Blood in nasogastric tube, active bleed. No blood in nasogastric tube, but there's melena, upper GI bleed. So nasogastric tube is very, very important. So aspirate a nasogastric tube could help you identify if the patient is bleeding currently or not. Anoscopy, proctoscopy in simple words. You have to visualize with rectal examination and proctoscope if there is bleeding from the rectum or not. What type of bleeding would it be? Fresh, red color bleed. Radiological studies. Radiological studies is very, very important. But before going to radiological studies, you have to maintain the stability of the patient. This can help you. Radiological studies can help you identify the bleeding points. The arteriograms, they can help you identify the bleeding points. So the interventional radiologist or endoscopist could help to find the bleeding point and can embolize and stop bleeding from the patient. So complete blood count, look for anemia, decrease HB. Hemoglobin less than 8 needs blood transfusion. Elevated WBC count, signs of infection. Inflammatory process, more common in inflammatory bowel disease. Low platelet counts. Thrombocytopenia, that's platelets less than 50,000. What to do with the patient with platelet less than 50,000? Transfuse platelets. If you don't, the patient might be bleeding again and again. Other important blood findings: increased blood urea nitrogen. Urea levels are increased. Why is this so? Because of decreased organ perfusion. Coagulopathy. So again, nasogastric tube is very, very important. As you can see in this diagram, is a nasogastric tube. You insert a tube from the nose that's go into the esophagus and eventually into the stomach. How do you do that? What's the significance of it? Significance is aspiration from nasogastric tube can help you identify two things: if the patient is bleeding or if this patient is not bleeding. Is the patient is having bile or no bile? Why is this so important? Because with patient who is bleeding, This patient needs an endoscopy, upper GI endoscopy. He's bleeding from upper GI tract. This patient can go into shock anytime. You have to be, and this can help you clear all the fluid, all the blood collected inside the stomach. And with that, the endoscopist can visualize the bleeding point more accurately and more easily. At times, when you pass on the endoscopic probe or endoscopic tube, the endoscopist could not visualize the bleeding point because there's just a lot of blood collected inside. And it's difficult for endoscopist to visualize the bleeding point. So with nasogastric tube, an aspiration of fluid or blood from the nasogastrium or nasogastric via nasogastric tube can help you clear the tract or clear the excessive amount of blood collected inside the stomach and help the endoscopist to visualize where is the bleeding point. So this is esophagus, this is stomach. You put on a tube from your nose from the nostrils back to the esophagus and then into the stomach. That's a nasogastric tube. Endoscope, that's proctoscope. As you can see in this diagram, it's a tube-like structure measuring 10 centimeters. What to do? You make a position for the patient for rectal examination. You put in the scope. You look for a bleeding point. If there is no bleeding point, think of some bleeding from upper GI tract or bleeding from lower GI tract but not rectum. But if it's rectal bleeding, that can be fresh, at times with blood, with stool or melena. This can help you differentiate any anal fissure, external or bleeding hemorrhoids, any fistulas who are bleeding in the rectal canal. So this endoscope or proctoscope is very, very important. This is a very simple test and can give you a lot of information. And if you find a bleeding point and that's easy to access, you can save the patient's life within no time. So radiological studies, as you can see in this diagram, this is a scan with contrast. What you can see, abnormal bleeding sites. The arrow shows the bleeding sites. Again, abnormal bleeding sites. That's in the GI tract. And this is also a scan with abnormal bleeding sites. So radiological studies is important, but before that, it's very important to go for an upper GI or lower GI endoscopy. That's endoscopy or colonoscopy. To do a lower GI endoscopy, that's called colonoscopy. It's a very, very important and very reliable thing. You can identify the bleeding point in 75 to 95% patients. You can identify and stop the bleeding point. Same goes for colonoscopy. But at times when it's difficult to find a bleeding point, these radiological studies could help you and find a bleeding point. So, let me summarize what we have studied today. We started off with GI bleed. What to do in a patient with GI bleed. How to manage, how to approach in a patient with GI bleed. Let me summarize it for you. When you receive a patient with GI bleed, look for the signs of shock. What are the signs of shock? Hypotension, altered mental status, increased heart rate, decreased temperature, decreased oxygen saturation. And what to do? First is airway management. How do you do that? Oxygen supply. If the patient is not maintaining with oxygen supply, go for mechanical ventilation, that's endotracheal tube intubation. Protect the airway is very, very important and the first step. Next is breathing. If the patient breathing symmetrical or not breathing symmetrically. If the breathing adequate. If the chest expansion is adequate. Next is circulation. Are the organs being perfused? Any signs of external bleed? Any signs of fresh bleed, especially coming from rectal examination? Next, if the patient is, you have maintained the stability or the patient is hemodynamically stable, then one should proceed with history and further examination. But before that, what to do? 2 large bore IV cannulas. Large bore IV cannulas is very, very important. Why? Because for rapid transfusion. This patient with GI bleed and he's hemodynamically unstable needs 2 liters of crystalloid infusion. The patient's lab investigation, which includes cross-match, PT, APDT, blood complete picture, liver function test, and renal function test should be sent as soon as possible. Blood should be arranged within no time. If there is no arrangement of blood, the patient could be given O negative uncross-matched blood. Abdominal rectal examination is very, very important to look for any bleeding point. And then there should be a consult from a gastroenterologist and general surgeon and the patient who is actively bleeding. This is how you approach a patient with GI bleed if the patient is unstable. When you achieve a stability and there are no signs of hemorrhagic shock, you can go for history and examination. What to ask for in history? What type of questions could be asked in a history? For example, from where it is bleeding from, for how long this patient you are bleeding, if it's associated with clotted blood, if it's coffee ground, fresh color blood. Identify if this patient is with upper GI bleed or lower GI bleed. Upper GI bleed is above ligament of Treitz and lower GI bleed is below ligament of Treitz. With upper GI bleed, you have hematemesis, melena, that's black colored stool, or haematochezia. But haematochezia is very, 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 very important sign in lower GI bleed. That's maroon colored stool or bright red stool. Or there might be no bleeding. That's also a sign of lower GI bleed. Examine the patient. How to abdominal examination. Look for any sign of tenderness. Rectal examination for any bleeding hemorrhoids. Proctoscopy for any rectal bleeding. And how to approach a patient with stable GI bleed and who should be considered to be admitted and who should be considered to be sent home and follow up in OPD department. Next, we explain what lab investigation should be done in a patient with GI bleed. Complete blood count shows a sign of anemia, that's decreased HB levels. Less than 8, the patient should be transfused, or patient with active bleed should be given blood. Blood to be replaced with blood. Crystalloid infusion could be helpful for some time, but blood should be replaced with blood. Next, renal function test, signs of hypoperfusion. Deranged renal function test, the patient isn't going into shock. Decreased urinary output. ECG in a patient who is elderly and can present to you with acute MI and acute GI bleed. Look for signs of chronic liver disease and liver function test. Any signs of abdominal examination, any signs of ascites, chronic liver disease sign. Very, very important thing. What blood cross-match, type of blood and blood type and blood cross-match, very, very important. If there is delay in arrangement of cross-matched blood, the patient could be given uncross-matched O negative blood. Radiological studies. what type of radiological study should be done. Again, patient who is actively bleeding should be considered or should be consulted with gastroenterologist for possible endoscopy in ER or as an emergency service. You stop the bleeding, you can save the patient's life. Nasogastric tube insertion help you to differentiate upper GI bleed, can help you clear the excessive blood, and can help the endoscopist to visualize the bleeding point. So in this part of upper GI bleed, we explained everything about how to approach a patient and GI bleed. And the next part will be specific on the diseases that present with upper GI bleed. And that's all for now. Thank you for watching sqadia.com.